Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Today, we're again handing the mic to our partners at Vital Strategies and featuring one of their Vital Talks podcast episodes. The topic, what if public health fueled social reform movements? Let's listen.
Well, good day, everyone. My name is Dan Cass, and I'm the Senior Vice President for Environmental Health at Vital Strategies. At Vital Strategies, we're working to reimagine public health. And that means everything that surrounds us, the built and natural environment, policies and culture, all of which make good health possible or conspire to deprive us of it. In the wake of millions of deaths from COVID-19, with economies shattered and too many lives impacted, we now have so much more to do to protect people's health. In today's discussion, we'll be looking into the history and evolution of public health and asking, what if public health fueled social movements? A recent article in The Atlantic by Ed Yong, entitled How Public Health Took Part in Its Own Downfall, took a thoughtful look at this topic and partly inspired this discussion. This article has a US-based perspective on public health and social movements, and we acknowledge the situation may be different elsewhere. So I'm excited to introduce you to our panelists. And before we get to the main event, we like to warm up by asking each panelist to share a news story that caught their eye recently. I'd like to introduce our three guests for today's discussion and also ask them to share a news article that caught their eye this week. It could be about this topic or not. Let's start with Celine. Celine Gounder is a senior fellow and editor-at-large for Public Health, Kaiser Health News. She's also an infectious disease specialist, an epidemiologist at NYU and Bellevue, and she's the host of two podcasts, The Epidemic and American Diagnosis. Welcome, Celine. What article caught your eye this week?
So there are really two news stories I want to highlight. One is the passing of Dr. Paul Farmer, who for many of us has been a mentor. For me, was certainly a mentor dating back to the 1990s when I was getting my start in the field of global health and HIV and TB. And there are a couple lessons I want to share that I think many of us have absorbed from working with and following his career. One is that I think is really relevant to the current moment is that infectious diseases are not the great leveler. I remember having a conversation early in the pandemic with a book editor who was encouraging me to write a book about COVID being this great leveler, and it certainly is not. I think very early on, when you're still learning, when it's still novel, it feels like everybody's at risk. But the reality, even early on, is that we saw that certain populations, people of color, low-income groups, and the like, were much higher risk for being exposed, infected, and then having poor outcomes. Secondly, Paul's concept of accompagnateur, or to accompany, be someone who accompanies, I think is really something that I at least try to do in my work, is to really be alongside the people that you're serving, to understand their experience, to embed yourself in the community and understand the community. Thirdly, this idea of preferential option for the poor, which particularly in this moment, as we're dropping many of the mitigation strategies, to be thinking about the most vulnerable and in a sense, providing the preferential option for the most vulnerable in this moment. And that includes, with respect to COVID, the elderly, people living in nursing homes and other congregate settings, communities of color, and then people in certain high-risk populations. We saw that people working in meatpacking, food processing, and corrections were also very, very high risk for exposure and severe disease early in the pandemic. And then finally, this concept of structural violence, which in some ways is what we're going to be talking about, really solutions to structural violence in our conversation today, which is how do our political, economic, and social structures create vulnerabilities where some people are at higher risk for being exposed, from suffering from various different diseases, conditions. The other piece of news I just want to very briefly touch on is today, Russia's invasion of Ukraine. And I think it's really important to highlight that disinformation, also known as propaganda, is a tool of war, and it's used to achieve political ends. And I think we should all be very alert to the fact that we are likely to see a lot more disinformation, not just with respect to Ukraine, but any number of issues in the coming weeks and months, and to double down on our efforts to really seek out expert opinion, advice, input on whatever the issue is that we're researching.
Thank you for that. Those are sort of great examples of things in the news that both look backwards and forwards to the role that we can play in public health as both practitioners and as a discipline. Let me turn to Shelley Hearn. Shelley is the director of the Lerner Center for Public Advocacy and the Dean Summer and Clagg Professor of the Practice in Public Health Advocacy at Johns Hopkins. Shelley, you may not know this, but I'm overdue by some 15 years in thanking you for shaping my own public health career. When you worked at the Pew Charitable Trust and the Trust for America's Health, you spearheaded the call for improved environmental public health tracking, which resulted in funding for the US CDC's program, which I helped launch in the early 2000s. So, Shelley, a belated thank you. What interested you this week?
Well, Dan, thank you. I didn't know that, and I actually think we'll come back round to that example of how you could take a critical issue that was not well understood, tie some important facts with it, and even though public health surveillance is not always the forefront of people's attention, there are ways to bust through the complacency, the lack of attention, the misinformation in the world, and actually be able to boost and improve our public health infrastructure. We did it in the past, and we can do it again. And let me use that to segue to the article that caught my eye was last night. The Post put out an article called Pregnancy-Related Deaths Shot Up During Pandemic's First Year. And this ties to what Celine was touching upon. And it's interesting that the header is actually not what the lead headline should have been. My hair is on fire. We all should be with what's going on with the extraordinary health disparities. It's not just what happened in COVID. It is alive and well with enormous differentials in health outcomes, in life and death situation between white, Black, Indigenous, people of color. The Post article, it basically captures that, yes, pregnant women, new mothers died at a higher rate in 2020, but that incredible increase was predominantly Black women. And this isn't news to us in the public health field. There have been reports going on for decades about this. And it's been actually, rather than improving, it's been increasing every single year. It just happened to continue also in COVID. This isn't about COVID. It could get confused that it is, but it gets back to this issue of one of the reasons that we will be the first country to surpass the 1 million deaths related to COVID is because we're one of the least healthy nations. And it's because of extraordinary structural racism that we have in this country, the disparities that we have not addressed despite. There was also a great article in STAT that captured what the National Academy of Sciences reported 20 years ago on this problem. And I say our hair should be on fire. This is something that we've known. We have not gotten it up to the level of creating the political will to start doing the investments that are needed, the attention and the drive to create the change. And I hope that's something I know we're going to roll up our sleeves and talk about a little bit more today.
Thank you. I think that's a great example that moves us directly into our next panelist, Daniel Goldberg, who is a historian. So this idea that we drag the history of inequities into every new situation, and until we solve them, it only worsens. Dan Goldberg is attorney, history of medicine, and a public health ethicist. Daniel's an associate professor at the University of Colorado Center for Bioethics and Humanities. And welcome, Daniel. What article would you like to share?
Thanks, everyone. Thanks so much for having me here on the Power Hour. I really appreciate it. So the article that caught my eye was a Kaiser Health News article. So just touching Celine there a little bit, I guess. And the article was referring to the raft of current anti-LGBTQIA plus legislation that's making its way across the U.S. Obviously, this is a U.S.-centric article for those of you who are listening from abroad, from elsewhere, non-U.S. listeners who don't know about this. There's a number of states who are basically passing all sorts of laws that are having a serious impact on LGBTQIA plus populations. Texas in particular came out with a fairly outrageous opinion from the Texas State Attorney General, and I've lived in Texas for 11 years, so I know the state very well. And so I guess the reason I was thinking about that and the reason that these struck me is because in my capacity as a public health law expert, one of the things that I work on very closely is something called legal epidemiology, which is the scientific study of laws and policies as epidemiologic exposures, right? And so it's kind of been known for a long time that laws and policies have a very powerful effect on health outcomes, but we haven't really studied them using sort of epidemiologic and public health science tools very well until probably about the last 10 to 15 years or so. And so I think, this is really powerful because we talk a lot about structural violence, and, one of the major upstream mechanisms through which structural violence, sort of these root fundamental causes like racism and sexism and ableism and other kinds of sort of forms of oppression, domination, subordination, one of the ways they get translated into health inequalities and health outcomes is through laws and policies. So laws and policies are actually pretty high upstream in terms of structural determinants of health. And so the laws and policies we form or choose not to form will have a huge impact on both the overall health of a population, whether it's the U.S. or not, and the state of health inequalities in the U.S. And of course, the health and the inequitable health specifically of transgender people and gender non-binary people in the U.S. has absolutely just been devastating. I mean, the inequalities are just horrifying to witness. And these kinds of laws and policies are obviously going to make things worse. And so it's very concerning to see these things happening.
Thank you for that. Following on this theme of policy, I myself was intrigued by an article this week that was in the Journal of Pediatric and Adolescent Gynecology that found that in the United States, it was legislation, that sort of notion of policy being a driver, was legislation that enabled robust emergency contraception access in adolescence was associated with a 14% reduction in adolescent pregnancies compared to states that restricted access, and that adolescent births were 43% higher in states with restrictive policy. So again, this notion of policies being so paramount. And it also brought to mind for me a couple of other sort of articles that appeared this week. First, the country of Colombia legalized abortion on demand through 24 weeks of pregnancy. And this step to advance women's opportunities to really exercise their reproductive rights and all of the health and social benefits that we know are associated with access to safe abortion came following a strong campaign by many women's organizations coordinated in Colombia by the Green Wave Coalition. And it's an example, to my mind, of how social movements aligned with public health advocates and public health data can really influence important public health advances. But the second article of the week, building on the theme, Daniel, that you began, related to legislation passed in Florida that reverses a woman's right to access to safe abortion. But notably, it too followed an adept and a prolonged and effective social movement, but this one led by a very small minority of the population. In the United States, less than 25% support criminalization of abortion, and it's led by our country's religious right. So there's a lesson. Social movements don't always move in the right direction for public health, and good public health advocacy doesn't always enable progressive social movements. So thanks, everyone, for sharing your news of the week. And I want to start with some questions for each of the panelists. And just we have a lot of questions to go through, so we'll try to keep our initial responses brief. Public health's greatest achievements are tied to social reform movements through things like housing and sanitation reforms. Daniel, your argument is that that's changed. Can you help us understand why that changed in the 20th century? And perhaps you can speak specifically about the decades that were of importance and compare them to the present day.
Sure, I'm happy to do so. I think there's a number of important, public health is obviously not just one sort of thing. It's not unitary thing in the US or elsewhere, right? And so while there's a strong tradition of social reform in Western public health in particular, there's also, of course, traditions of, and I'm thinking of Dr. Farmer's legacy here, there's also traditions of colonialism, imperialism, racism, and structural violence in public health. And all of these are part of the history, right? And so thinking about trying to sort of pick out the extent to which social reform movements have allied with public health, Dan, there's no question that they have, and that's been, I agree with you, the most sort of powerful union and alliance in the service of improving overall population health and compressing health inequalities. So over the course of the 20th century, however, this sort of emphasis on social reform, that is just one among many traditions in US and Western public health, in particular, really started to erode. And it's a complex story as to why and how this happened. One of the features that has been the most interesting to me is the rise of medicalization. And medicalization means all sorts of different things. It does absolutely mean the rise of professional medicine as a field, of course, but it also includes the idea of health itself becoming medicalized, that health itself is really seen as a function of access to medical and healthcare services. And of course, there's no question that medical and healthcare services are very important to overall health. They absolutely are. But we also know that it's not access to health. Medical services is not the prime determinant of health and its distribution in human populations. And that it's really structural determinants in which people live, work, and play that are the prime determinants of health. And so, that's the things we really need, sort of the priorities, in my view, and this is just one guy's view, but in my view, those are really the priorities. That's really what we should be focusing on. And over the course of the 20th century, public health has kind of moved away from that a little bit. We still are able to do lots of good for lots of people, but the extent and the scope of our services and the infrastructure that we've built to really implement structural change, to really sort of ally with social reform movements and to implement social reforms and to help where we can, that's really eroded over the course of the 20th century. And this is not to sort of say that's medicine's fault. It's much more complex than that. It's a social phenomenon in the US we've all participated in. And you can see medicalization elsewhere too. It's not just in the US. It just happens to be extraordinarily powerful. So it's a complex story, but sort of the rise of thinking about health primarily as a function of access to healthcare has, I think, contributed, to the erosion of public health capacity to really partner with social reform movements to implement structural change.
Just to follow up, are there exceptions to this sort of trend that you've observed in the 20th century and early part of this century, and where there have been very strong social progressive movements that have emerged? Has public health done a decent job trying to align with them?
Oh boy, that's a really good question. Yes, of course there are examples of this, right? I mean, the one that most readily leaps to mind is, maternal child health, which is not my particular area of expertise within population health, but I know that MCH, maternal child health, remains sort of very powerful and significant in public health training and education. And of course, there were women's movements in particular, led by women, organized by women, really sort of focusing on maternal and child health beginning in the early 20th century. That I think public health was probably a little bit better to allied with a little bit better for complicated reasons as well, not always because it was just sort of fueled by an interest to compress health inequalities and reduce violence. That's part of it. But political alliances are always more complicated than that, right? So that's the one that leaps to mind, is I think that there were substantial improvements in maternal and child health. But as sort of Shelley talked about in the beginning of the show, we also have seen tremendous inequalities, including terrible infant mortality statistics in the U.S., which track racial lines, right? So, Black mothers are, much less likely to be healthy in terms of giving birth, right? And that's because of structural violence and racism in this country, make no mistake about it. So, while there have been some successes, I would say, with maternal child health and sort of social reform, there's obviously, also been some failures, and we're accountable for that in public health.
Thanks for that. Celine, you've been a really prominent voice on equity during the COVID-19 pandemic. To what extent can the many failures in the global COVID-19 pandemic response, like supporting the vulnerable from economic hardship and equitable vaccine access and ongoing access to care, to what extent can these sort of problems be tied to public health's alignment or failure to align with social movements to drive these kinds of hoped-for public health advances?
I think part of the challenge here, Dan, is, if you look at attempts, say, by the current administration to provide some of these social safety nets, say, for example, paid sick and family medical leave, which was one of the bills, but not passed. because of the way we pass these things in very fragmented approaches, you may have, for example, vaccination requirements passed, but not the measures that would be necessary to make it easier for somebody to access vaccination. So what we're seeing, and this is something we've seen in Kaiser Family Foundation polling, is that communities of color, lower income groups are very worried about side effects from vaccination, are less likely to seek it out, in part because they are worried about missing work because they might have a side effect. And a day or two of work can be a big deal if you are barely making ends meet, if you don't have that paid sick and family medical leave, and even the emergency leave that was provided over the course of the pandemic that has since expired. Only about half of people who were eligible were even aware that such safety nets existed. So I think, unfortunately, the way we approach these things, it's piecemeal, it's not transparent. People aren't even aware when there is something available to them. And that remains a big challenge.
Yeah, I mean, do you feel as if this sort of notion of fragmentation, are there signals that public health as a field can, really influence the defragmentation of these issues, or are we doomed to, at least in the United States, to continue this notion that every sort of field argues on behalf of itself?
I think that remains to be seen. I think it remains to be seen how much public health, I think people have at least a little bit better of an understanding of what public health is, although I think sometimes that understanding is not a positive one in the minds of many, unfortunately. This nanny state, this telling you have to wear a mask or that you have to get vaccinated. And I'm still not sure that there's been a positive, productive narrative of public health that will lead to its better empowerment and funding. And in fact, over the course of the pandemic, and this is something that Kaiser Health News has very well documented, public health has been, even now, still underfunded, has been under attack. We've seen the loss through firing, people quitting, tiring, and not being replaced, the loss of a lot of public health leadership and institutional memory. And so unless we reverse those trends and empower public health authorities, provide the appropriate funding, I think it's going to be very difficult for public health to lead in that way. And, I think that is sort of the philosophy of public health, this more holistic approach, but they need to be resourced and empowered to lead that way.
Turning now to you, Shelley, drawing on a couple of themes that have emerged, are both the kind of historical look back at successes and this notion of sort of the future of public health. Your field has been environmental health for much of your career, and some of the more successful examples of these alignments between public, sort of emerging public health and social movements really are around the sanitary reform movements that began in the late 19th and early 20th century. How do you see public health playing a more active role as you imagine a different future?
Well, let me riff a little bit off of the point Celine left off, where we need to pay more attention to the challenge that we have, that the public health system is under-resourced and challenged in this day and age. If anything, it's the dirty secret has been exposed that we do not have a public health system. We don't have a connected, strengthened, we don't have the laws. We don't have inadequate numbers of staff, the laboratories. I mean, it's a long list that we don't have the infrastructure in place to give us a chance to become one of the healthiest nations in the world. And there's a historical aspect to it, and I think Dan had touched on this. Let's take a look at what happened with the environmental movement. Go back 50 years ago, we had some terrible events going on in this country. The Cuyahoga River on fire, literally in Ohio, for years. They could not put out the flames because the river was so dirty. My home state of New Jersey was the brunt of every hazardous waste joke that could be named. And if we had time, I would give you plenty of them, and we'd be rolling our eyes. But it was a reflection of the extraordinary problems that we were having in this country. Those were actually, it should have been the authorities of public health agencies, but they didn't have the capacity. And we rebuilt in this country and created a whole new infrastructure to deal with our environmental challenges. The EPA was put in place. We created state environmental agencies. There were very clear laws that defined what chemicals would be regulated, what would be reported, how they would be reported on an annual basis. Now, fast forward here to diseases, which are just as toxic, just as dangerous to the human body as toxic substances. But we don't have a disease tracking system in this country. It's why we were left so flat-footed and behind the eight ball when COVID hit, and we were not able to require states to report on COVID deaths. We did not require them to report it demographically. We could not get race data. We started to see, and it was not a surprise, the extraordinary disparities that took place with COVID. But if you don't track it, you can't tell it and you can't fix it. And it's such a basic thing that we haven't actually even built for public health. It's where we have got to think about turning this around, turning this moment, and yes, highlighting the challenges that we've got in the public health system so that we can go in there and fix what is long overdue, whether it's chronic disease, COVID, climate. The disparities that we have in our health outcomes are unacceptable for a country of this wealth and capacity.
You know, I'm struck by a couple of tensions in the discussion thus far, and Daniel, maybe you can comment on one of them. One is that, you know, both Celine and Shelley have sort of pointed out the under-resourcing of public health, and so the re-resourcing or the adequate resourcing of public health would certainly strengthen, you know, the availability of data and the capacity to respond, and you know, the sort of leaning into the science. That, to some extent, feeds into this notion of the medicalization of public health. On the other hand, you know, the more public health leans into an advocacy role, aligning with social movements, the more it can be accused of being partisan, thus, you know, potentially sort of undermining this, you know, sense of trust. And maybe you can comment on that. Does it make sense for public health professionals, you know, to be formal advocates for social and political systems that support public health that are not directly in, you know, our wheelhouse of strategies?
So, Dan, I'd say yes, but I've actually, believe it or not, written something about this, right? And it has to do with the debate whether over what's been referred to as a broad versus a narrow model of public health, right? The idea of a narrow model of public health is that it sort of sticks to what's been referred to as the 10 essential public health services, right? Which is how public health sort of local public health departments have been organized, or whether it takes a much broader view on things like social and structural reform, as we've been talking about. And of course, there are advantages and disadvantages to each, and both traditions are represented within the history of Western and U.S. public health in particular, right? So the problem is something that you sort of have already touched on, and I've referred to it as sort of the ethics of health policy paradox. And what that is what we ought to do may not be what we can do politically, right? And what we can do may not be what we ought to do, as it turns out, right? The things that we can do may not actually be the things that we ought to do. I've written in favor of a broad model of public health because I think we really don't have any other alternative but to try to make a world in which we are really sort of addressing the structural determinants of health and its distribution in populations. I think, unfortunately, too much of public health action over the course of the 20th and even into the 21st century has really sort of taken the narrow model of public health for a lot of different reasons, many of which I actually understand and have already been touched on in the Power Hour so far. But by doing so, you almost guarantee that the actions you're taking are not going to have a huge impact on improving overall population health and compressing inequalities, because they tend to address downstream determinants of health, right? And so I understand why we're doing those things. It doesn't mean that we can't do any good by addressing downstream things, because we can and we have, and I hope we will. But you're not going to see fundamental change on the kind of indicators that Shelley was talking about if you don't actually sort of, engage in collective political action. And I guess that's the other point I was raised, is that public health action is fundamentally political, and it's always been fundamentally political, right? So, I'm one of those people who really doesn't like when I hear things like, we shouldn't politicize public health. I've written on this too, Dan, to be honest with you. I kind of just roll my eyes because, public health is fundamentally political, and that's not always a good thing. I'm not saying that's an unqualified good. It's not. It's actually extremely messy and problematic in many ways. But I just don't see any other alternative if we want to have the kind of impact that we could, at least in theory, have through public health action.
So, Celine, maybe just turning to you on that, let's sort of try to think in kind of practical, mechanistic terms. What would it look like to be more political in public health? Can you think of sort of examples from your own work or from, as you sort of touched on in your tribute to Paul Farmer at the beginning, really sort of getting to know communities? What would it mean for public health professionals to be more overtly political?
I do think it's important to distinguish political from partisan, but I think, when you're talking about the distribution of scarce resources, which is very much what public health tackles among other issues, that is inherently political. You can't get away from that. And there are values that determine how resources are allocated, what is emphasized, what is prioritized. So whether you call it values or political, I think you can't get away from that. Now, what might that look like? As Bill Foege, who was one of the leaders of smallpox eradication, a former CDC director, has said, the philosophy of public health is to protect the most vulnerable and to emphasize those safety nets. And so I think, that is remains really the philosophy of public health. And so that should be how we structure our thinking. And it's not just a question of what is moral, although I would argue that is what is moral, but also where are you going to have the most impact across a population? And public health is focused on the public, on populations. So your goals, your priorities are going to be different from when you are a clinician in a hospital and in your office examining a patient. Your priority is the patient in front of you. With public health, your patient is the population. And so where are you going to have the greatest impact? It's really on focusing on the most vulnerable, where you're going to have the greatest incremental impact. Now, what are the specific things that public health leaders can be doing in this moment? I think one is being that moral voice of saying, look, this is what's happening to the most vulnerable. I've been really proud of many of my colleagues in this moment who have taken to the airwaves, to writing op-eds, to leading virtual town halls and all the rest, to lead and to care for the most vulnerable in this moment. I think that's an important role here. I think another really important role for public health is to be in community. And I think, one of the promising changes over the course of the pandemic has been some revitalization of community health worker workforces. And some of this has happened through funding from the CDC. And it's really across the country that we've seen resources put into community health workers. These are people who are from community, who are working in the community for the community. It is a very tangible extension of government in the community where people can see services, can trust that something is happening for them on behalf of them. And I think, that is in itself, in a sense, political. But I think that's a really important place to start in terms of helping to re-engender trust, both in public health and in government.
Yeah, it's very interesting. I'm sort of struck by, the data that's emerging around the efficacy around overcoming vaccine hesitancy being really driven by community voices and community practitioners, So to see this component of the healthcare delivery system, community health workers, being an arm of public health, I think is a really interesting observation. I want to sort of stay on this theme of what it looks like for public health to be more explicitly values-based, politically engaged. And I agree with you, Celine, that political is not the same as partisan. But I also want to maybe think a little bit about the workforce in public health. I'm a veteran. I've been in public health for over 30 years. Without overstating these sort of generational differences, I do observe, from my own career as someone who's hired, sort of hundreds of people in public health, that when I sort of entered public health school, I remember my cohort of public health students being largely arriving at public health through a kind of an analysis of how to impact populations and how to align their personal political values, ideology with something in the health field. And over time, it became much more driven, to my mind, by folks who were really pursuing a kind of technical dimension to the work. And I don't know whether we're seeing a reversal of that in association with some of these new youth-oriented or youth-driven political movements in the United States. Shelley, what do you think? I mean, you've been involved in really trying to shape the nature of the public health workforce. What do you think the next generation of practitioners will look like? How can we shape them in this direction?
Let me jump in with survey work that was done by De Beaumont Foundation and the Association of State and Territorial Health Officials that looked at what were the needs, the skills of the current public health workforce. This was a few years ago, before the pandemic, but one of the issues that came up loud and clear is that it was recognized the need and the skill for engaging in the policymaking process was a critical one, yet most people lacked it. And that I suppose has come to light even more so in the challenges that we've been facing with our governmental health agencies in how to engender trust, how to engage in the policy process. And I want to echo what was said earlier. Being able to be effective in policymaking is not a bad thing. It's actually the most vital skill that we need today. And we have to build that and boost that in our next generation and our current workforce. We have been frightened and scared that it is seen as political, somehow partisan, when in fact public health, some of the best, our greatest impacts in a healthier world have been through public policy. That's a critical element that we have to be able to effectively roll up our sleeves and be part of that process. The National Academies of Sciences have called for that in public health, our own surveys. And so what I'm actually starting to see in the flood that has been happening at schools and programs of public health in this country since the pandemic has started, we have more people wanting to come in who want to be part of the problem solving, who get it that it's not just COVID, it's chronic disease, it's the extraordinary disparities that we've got to use the policymaking process as a way. And this next gen is not seeing advocacy as a dirty word. They're seeing it as a critical skill. And in fact, it's now being built into the accreditation requirements of schools of public health, that we have to be fluent in how we engage so that we're able to be out there, able to be known, able to be trusted, and start getting that ability to really make the shift and change. So folks are hungry. And even us, gray hairs who've been out there doing it for a while, our colleagues are saying we need that training now more than ever. So that's where we've got to go all in.
Yeah, that's interesting. I mean, speaking for our own organization at Vital Strategies, we work globally, often alongside and by embedding staff in ministries of health, trying to attach resources to critical public health analysis and aims. And we have found ourselves this growing demand internationally for policy development engagement. What are the understanding how to really develop strong policies, make the evidence for them, but also the softer skills, the advocacy skills. And this is where, at least, speaking about sort of the earlier generation of public health trainees in the United States and even globally, I agree. I think it's not been there, but it's nice to hear that it's growing. Celine, do you, sort of thinking about this kind of global theme, Do you see examples globally where this alignment of sort of public health, social movements, advocacy, explicit attention to the vulnerable and to eliminating disparities, not just in outcomes but in risk factors? Do you see good examples globally where this is happening?
I think certainly, in the context of HIV. I have seen that kind of advocacy in the field on the ground. And I think, thinking back on my early years working in places like South Africa around 2000, where there was this discussion of does HIV even cause AIDS? So you had this, in some ways, very similar moment to what we're experiencing right now of this intertwining of what I would say are political interests with disinformation, with public health. But I think the recognition in that context that people have a right to health, which is not a right that is recognized here in the United States, but in South Africa is, and they have a right to at least some basic level of healthcare. I think is part of that kind of intertwining of understanding. And I think some of the greatest advocates for global vaccine equity right now are voices from the global South, who unfortunately are not necessarily in the position. If you look at where are the major producers of vaccine right now, Pfizer and Moderna, they're in the developed world. And the levers of power to force things like sharing of vaccine technology to make that available to the global South for regional self-sufficiency, there's only so much that those advocates are able to do. But I think some of the most powerful voices in highlighting these inequities are coming from that world. And I think in some ways, when life is so precarious and where democracy, where it exists, is much newer, people have a better understanding of how these things relate. I think some of the most sophisticated thinking I've heard, frankly, on the intersection of culture and politics and health has been in places like West Africa, where I was working during Ebola, and hearing even just lay people talk about our politics in the US and how that was influencing what was happening on the ground for them. I think there's just a greater awareness of how these things relate.
Thanks. I'm struck by maybe the sort of the converse of what you're describing. So let's sort of take the example of, clearly global trends in the diminution of democracies in many countries that had felt more secure, democratically, and the overt suppression of mass movements. I'm trying to, harken back to this notion of, it's been mass movements aligned with public health that have really influenced public health outcomes, and where mass movements are being suppressed, and I'll open this up to any and all of you, where do you see public health, those of us in public health, making a difference amidst this kind of suppression effort for mobilization?
Well, one thing I'd like to say on the social movement question is, if you look at how social movements rose, sort of the beginnings of the progressive era in the United States, what was happening at that time, you've had very strong moral voices, as we do today. At that time, it was around issues like child labor and housing, and today it's about global vaccine equity and vulnerable populations. But I think that is one of the sparks of what starts a social movement. I think having trust in institutions and in one another is another really important piece here. And I do think, again, that community health worker initiative that we're seeing across the country could be another spark that helps to start to build a social movement. But I think, thirdly, we have to understand the challenge of collective action. And I recently went back and reread Menser Olson's The Logic of Collective Action on this issue. And I think fundamentally, very often, policy is driven by a very small number of people who are highly motivated and have the time and energy and resources to have influence. And a lot of us are just getting by, barely treading water with all of the different things we have that we're juggling in life. And really the only way to sort of democratize some of that is to make it easier for people to participate. And I was recently talking to a friend and colleague of mine, Gary Slutkin, who's spent much of his career working on gun violence. And, I mentioned this or said something about this to him. And he said, well, you have to pay people. That's, kind of what community health workers are in a sense, is they're a paid workforce of people who are the foundation for a social movement. But you have to enable them to participate. And I think, until we facilitate that, it will be an activity of the elite to be speaking out, to be calling attention to these issues. And so I really hope that perhaps in this moment that's changing.
Daniel, from your historian perspective?
I'm not sure I have a whole lot of wisdom to sort of offer on this one. Not because I don't think it's an important question, Dan. I think it's a critically important question. But, I'm not sure I have, that it's fair to say, at least in the history of U.S. public health, I'm not sure global public health might be a little bit different, but in the history of U.S. public health, I'm not sure it's fair to say that, there are tons of examples of where public health leaders have been out in front of social reform movements. Sometimes there have been important alliances, as I think we alluded to earlier, and that's great. Those partnerships and collaborations and alliances become important. But for a variety of reasons, I'm not sure that organized public health has really been at the forefront of sort of social reform movements, which doesn't mean they couldn't be. I'm not opposed to it at all, actually. In fact, I'm strongly in favor of it. I don't know that I have a lot of wisdom as to sort of the mechanics of how that happens. I mean, I think Celine's point is obviously extremely well taken, that it does, that these kinds of sort of policy processes can become often are sort of the province of the elite, right? And I think that's part of the problem. There's a lot of efforts involved in community-based and community-oriented policymaking, and sometimes that works better than others. The expression is all public health is local, right, including global public health, and so, there are sort of local movements where you can get sort of partnerships between important public health programs, public health advocacy groups, and community groups. And there are, I think, that, examples of ways in which those things can be successful on the local level. I'm not sure how that sort of translates upwards to state and national, and let alone sort of global health policy. But those kinds of things are a little bit beyond the scope of my particular expertise. So I'm sort of eager to hear what Shelley has to say about this.
Well, let me offer a few thoughts. I think we have seen, whether it's from the environmental movement, where it is a combination of sentinel events that bust through and get the kind of attention and people saying, we ain't going to take it no more, in combination with a healthy, robust advocacy community that the public health arena, I think for most of our field, it's in an infancy state. We have a lot of issue-specific groups, but we don't have the kind of political muscle that you have seen on climate change or in the LGBTQ community. But those also took time to grow and germinate around sentinel events that are a combination of a timeliness, a public outrage, sophisticated organizations. Yes, there's investments by elite of money and connections, relationships with those in policymaking positions who could champion and move issues. But that's what we have to start thinking about more concretely in building. And are there ways that we can knit together our diffuse public health groups? We have some very strong gun violence organizations. They've been hampered for a long time by the lack of a public health infrastructure that could even track basics on gun violence statistics, because CDC was held back from that. We go environmental. Dan, you talked about how much of your career was on building those environmental health tracking capacity, and how that happened, and the engagement allowed for better trust, better information to the public, better transparency, and better action. And so we're at I feel like the public health field is at the very early stages of the potential to really be a player, and to not just be a bully pulpit, but actually be able to start to convert this sentinel moment, start to strengthen some of the organizations that are out there, and to be more political. And again, not partisan, but to have and engage in the policymaking process so that we can actually strengthen our capacity to create those healthier environments for everyone. It is time. It's just time.
We're coming up on the close of our time. I would just invite Daniel and Celine to also maybe offer some closing remarks on this discussion, and perhaps point our listeners to any additional resources you really recommend for reading or for viewing around these topics.
So in terms of another reading or other readings, I would recommend the work of Robert Putnam, who wrote Bowling Alone, and then with Shailene Romney Garrett wrote The Upswing. The three of us actually co-authored an op-ed in Time recently entitled How America Can Rebuild the Community Bonds It Needs to Face the Next Pandemic. And I think at the root of a lot of our problems are the balance between the individual and community. And that there have been sort of parallels between what we've seen with social movements, with public health, and those track very closely with the balance between the individual and community, whether that balance is healthy or in the current moment has gone to a very far extreme individualism. And I do think that, looking at how we can rebuild a sense of community is going to be really important to rebuilding public health. Thanks
for that. Daniel?
Just in terms of sort of some closing thoughts. I mean, I sort of think it's interesting just looking at the title of the Power Hour here. What if public health fueled social reform movements? I think it's important because I don't think that there's a huge history of that. There is a history in which public health has allied and partnered with different kinds of social reform movements, but actually fueling them themselves, I think, would be relatively novel. I don't want to say it's never happened before, but I wouldn't say that it's extraordinarily common, at least in the history of U.S. public health. So, I think that that's one of the messages going forward is, to sort of Shelley's point, is not just what if, public health sort of participated in social reform movements, but what if it took, what if its workforce took a hugely active role in sort of, shaping policymaking processes? I think that would be quite interesting in the interest of sort of changing laws and policies, that impact sort of structural determinants of health, right? So in terms of whose work would I sort of recommend going forward? I mean, a colleague and a collaborator whose work that I'm sort of heavily engaged with right now is Paula Lantz. And Paula was at University of Michigan for a long time, and she works a lot she's a social epidemiologist by training, but she has a huge foot in policy and has been working in trying to bridge the gap between what the social epidemiologic evidence tells us in terms of structural violence and the kinds of public policies she makes, with a particular emphasis on the medicalization that I talked about earlier. A lot of my thinking about medicalization has been heavily shaped by Dr. Lantz. And so she's got a lot of, I think, very accessible work on this. And so I'd recommend that to anybody.
Terrific. And Shelley, you get the last word.
So the reading I'd suggest is a recent book by Tony Eiten and Harry Snyder that is advocacy for public health policy change and an urgent imperative. And it's put out by APHA Press, really recognizing what we've been talking about, that we really need to start making this part of our standard operating practice, that where we have, as Dan was noted, in past decades, focused more on a medicalization approach to populations. The reality is the research and data is showing that it's the policy environment that we create that can lend, as you address, everything from structural racism to better opportunities for all, that it's policy that is going to be some of our best opportunities for creating better health. And so that thinking of how we all can be advocates and what are the different roles and ways that we can partake in that, depending on where we are, that book is a good place to start.
Thank you. And thank you to all of you, our panelists, Celine Gounder, Shelley Hearn, and Daniel Goldberg, for really a wonderful and thought-provoking discussions. And thank you all for joining as listeners.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.